Hello and welcome back to the channel. If you are new here, then hi, my name is Brittany and I am a nurse practitioner. I'm also the owner and creator of Brittany Holzbeck NP Review. If you are a returning subscriber, then hello, welcome back. As always, you know I'm so happy to have you here. For today's video, I'm going to be giving you a sneak peek of the new 3-hour pharmacology crash course that has just been added to my Total Nurse Practitioner Boards review. So in this crash course, I cover all of the most commonly tested on medications and treatments for the Nurse Practitioner Boards exam. And of course, it's just also extremely useful material for the new nurse practitioner entering practice. Even the established nurse practitioners that just want a refresher, you could definitely learn something too. So in the course, I cover all sorts of medications, including NSAIDs, bisphosphonates, levothyroxine, metformin, GLP-1, SGLT2s, DPP-4s, insulin, iron supplements, ACE inhibitors, ARBs, calcium channel blockers, statins, digoxin, warfarin, oral anticoagulants, short-acting beta agonists, long-acting beta agonists, various forms of birth control, SSRIs, and seriously so much more. That's just touching the tip of the iceberg, so to speak. In this video here, I just wanted to give you a free preview of what you would expect to see in this lecture. And so I'm actually going to share with you the first 20 minutes. And in this, we'll be discussing NSAIDs, bisphosphonates, levothyroxine, and then metformin. To access that complete lecture, then go ahead and visit patreon.com/BrittanyNP, and I'll put that up here on the screen for you. Also, as a bonus, for a limited time, I have made this crash course available for only $20. And not only that, but if you do sign up for the pharmacology crash course, then you will also gain access to all of the content available under my $5 tier as well. And so this includes things like case studies, visual aids, help with lab interpretations, and honestly more. So it is available on the $40 complete review course where you get all of the system-based lectures. But if you just want to take a look at the pharmacology crash course, then you can actually access it for only $20. And like I said, you also then will get all of those other additional videos and content to help you as a nurse practitioner entering practice. All right, so without further delay, because that was definitely a mouthful, let's just get into the material. All right, so first up, let's discuss NSAIDs, or those non-steroidal anti-inflammatory drugs. So NSAIDs, they're often used as a first-line pharmacological treatment option for orthopedic injuries. And though this drug class, it can be very useful, it does come with a set of known risks. It's also highly likely to come up on your board's exam, so it does deserve some special attention. So real quick, I want to do a brief review just to help with completeness and comprehension. So the body produces two enzymes that they're called cyclooxygenase enzymes, referred to as COX-1 and COX-2. And these play an important role in perfusing our kidneys and the production of prostaglandins. And prostaglandins, these are known to cause pain, fever, and inflammation. So thereby inhibiting these prostaglandins, this helps to reduce pain, reduce inflammation, and or reduce fever. So importantly, COX-1, this promotes platelet aggregation, and COX-2 decreases platelet aggregation. And this effect that they have on clotting has a lot to do with potential negative or potential positive side effects associated with these agents. So an example of a COX-1 specific NSAID would be aspirin. This is why this drug has been used so much in our CVA patients and also our cardiac patients, because it does reduce the risk for clotting. And then an example of COX-2 specific NSAID is Selexcoxib. This increases platelet aggregation. And then there are also non-selective NSAIDs. So that would be ibuprofen, naproxen, ketorolac, and then diclofenac. And these are referred to as non-selective because they act on both COX-1 and COX-2. And so it's really important when prescribing NSAIDs to consider, of course, the benefits, but also the risks associated with these agents, just like any other medication that we'll be prescribing. And so I'm going to cover those now, but really focusing in on the risks involved with NSAIDs. So as mentioned, there is an increased risk of bleeding when taking NSAIDs due to the inhibited platelet function, and so they're contraindicated in patients that have either suspected or confirmed CVA bleeding or those that have an increased risk of bleeding. There's also a concern for the increased risk of a cardiovascular event, including a myocardial infarction. And this is because there is an increased risk for thrombosis with the use of NSAIDs. Because remember, those non-specific NSAIDs act on both the COX-1 and the COX-2. Additionally, due to the reduction of perfusion to our kidneys with NSAIDs, this can cause increased sodium retention and increased fluid retention, which in turn results in worsening hypertension. Also, there's of course another population that we want to have on our mind when we're concerned for fluid retention. I'm sure you can guess it, but that's our heart failure patients. Much of their symptoms and their disease is associated with fluid overload. And so the last thing that we want to be doing with these patients is increasing their fluid and sodium retention. Also, there is an increased risk for GI events, those gastrointestinal events, when using NSAIDs. So things like peptic ulcers, GI bleeding, even so far as a possible perforation. And so we want to avoid NSAIDs in patients that have, of course, again, active bleeding, but also if they have a history of these GI events occurring. Also in patients that are taking blood thinners, because this together would increase their risk for a bleeding event to occur. And then finally, there is an increased risk of renal injury, and that's of course due to that reduced blood flow to the kidneys. So this can cause a reduction in the GFR and ultimately can cause an acute kidney injury. And so we want to avoid this drug class in patients that have already established kidney disease, if they have hypovolemia, patients that are taking specific medications, so specifically diuretics and ACE inhibitors, they would be at more of an increased risk with a kidney injury, or patients that are 65 and older, because that alone puts them at an increased risk for injury to their kidneys. And so as you can see, though NSAIDs are so commonly used, right? They're available over the counter. People are constantly using NSAIDs, and they can be very quite effective, when thinking of, reducing inflammation, reducing fever, but they do carry a lot of potential risks. And so as with everything, it's always important that we're weighing our risks and benefits. But because this is such a medication that's used so frequently, you can definitely expect to see this on your boards exam, and you definitely want to have in mind those populations that should be avoiding NSAIDs. And in the circumstance where NSAIDs should be avoided, acetaminophen is often used as an alternative option. It is not as effective, especially because it's not an anti-inflammatory, so for pain, but it is used as the alternative if they cannot take NSAIDs. All right, and so let's move on to the bisphofonates. So this is a first-line treatment option for osteoporosis. Examples of those would be alendronate or risdronate. Most frequently used would be alendronate. That is the one that I think that you would most commonly see. So these drugs work to reduce bone breakdown, and they do so by slowing down the activity of those osteoclast cells. And if you remember back, osteoclasts, they work to break down bone and to initiate normal bone remodeling. So this drug class slows that process down. It's important to note that with those bisphosphonates, that drug class, it is contraindicated in patients that have esophageal disorders. So this includes strictures, varices, Barrett's esophagus, if they are unable to sit upright for at least 30 minutes, or if they are unable to swallow pills. Also, if they've had a gastric bypass. So that drug class needs to be avoided in patients that meet any of those criteria. In the circumstance where they are not able to take the oral bisphosphonates, there is IV that's a mouthful. IV bisphosphonates available called zoledronic acid. So the point is that there is IV available if they're not able to take the oral medication. For patients that have been started on this therapy, the bisphosphonate therapy, it's recommended that they get that repeat dual energy x-ray of their hip and spine after 2 years of using the medication. For patients that took alendronate or risdronate for 5 years and they are found to have stable bone mass density as determined by that repeat x-ray, if they've also had no previous vertebral fractures and they have a low risk for fracture, then those medications can actually be discontinued after 5 years of use. But they need to have that repeat x-ray to make sure that they are having stable bone mass density, and again, that they don't have that history of high risk for fracture or vertebral fractures. All right, so next up, we're going to be talking about the endocrine medications. So for this system, I'm going to be focusing on levothyroxine and then our diabetes medications, so metformin, insulin, also those others like the GLP-1s, the SGLT2s, the DPP-4s, the thiazolidinediones, and then the sulfonylureas. Oh my goodness, that's all such a mouthful, but we'll get into those more. But so our diabetic medications and then our levothyroxine for our thyroid patients. And so first up, let's talk about the levothyroxine. So all patients that have established hypothyroidism, regardless of their symptoms, they need to be treated. And so luckily the treatment for this, it's really straightforward. The choice of treatment is synthetic T4. It's also known as levothyroxine. The goal of treatment for these patients is to normalize their TSH or their thyroid stimulating hormone. So initial dosing for this, it can be started at the intended full dose unless, and this is an important caveat that you could be questioned on, unless our patient either has established heart disease or if they are above 60 years of age. So generally, if they do not meet these criteria, so they're less than 60 years old, they do not have cardiac disease, the typical dosing for the levothyroxine is approximately 1.6 micrograms per kilogram per day. However, and this is like really the important overall theme here, is that if our patients are higher risk, so again, greater than 60 years, or if they have cardiac disease, then we want to be starting them on a lower dose of the levothyroxine. So typically it's 25 to 50 micrograms daily, and then you would remeasure their TSH in 4 to 6 weeks. And then depending on those results, you would titrate to achieve those normal thyroid levels as needed. But the idea is that with those patients, we're starting lower and slower. If they don't have those risk factors, then we can start them at the intended full dose, no problem. So there's something to keep in mind if they ask you something like that on your boards exam, just a kind of a red flag. After beginning the levothyroxine, it's recommended to recheck your patient's TSH and assess their symptoms 6 weeks later. So their symptoms, they're expected to improve about 2 to 3 weeks after medication use, but it can take up to 6 weeks really for their TSH to correct. And then once a normal TSH is reached, then we can repeat their TSH only one time a year. That's all the indication, that's all the literature says that we need to be doing, is repeating that TSH once a year once we've reached that desired TSH level. It is important to note, though, however, that there are various factors that can require an increase in dosing, a big one being pregnancy. And I can speak to this. You may know that I've had thyroid cancer in the past. I have had a complete thyroidectomy, and I take levothyroxine. And typically my dosing would be, I believe I started at 100 micrograms, and my TSH remained normal for years. This was when I was 17 years old. I'm 34 now. I really don't ever have issues except for when I'm pregnant, and this is a very common thing that occurs. Right now I'm taking 137 micrograms of levothyroxine. At one point during my pregnancy, my TSH was actually 14.9, which is really crazy and out of whack, and that's not that abnormal with our pregnant patients. And so that could definitely be a question that could pop up on your board's exam, and obviously just in practice too, you want to have that in mind, that if you have a pregnant patient that is on Synthroid, that we really need to be keeping an eye on their TSH, because it's not uncommon for there need to be an increase in their dosing. Other factors that could require an increase in dosing would be estrogen therapy, or if they've had weight gain of more than 10% of their body weight. And then the last little and important point here is that you educate your patients to take their thyroid medications on an empty stomach with water, ideally 30 to 60 minutes before breakfast. But really the important component there is that they're taking it on an empty stomach. All right, so next up, let's talk about metformin. So if there are no contraindications, then metformin is used for initial therapy for our type 2 diabetic patients. So metformin belongs to the drug class biguanides, and it can successfully decrease a person's A1C by 1 to 2%. And it does so by decreasing a person's hepatic glucose by inhibiting gluconeogenesis. And so contraindications to metformin are going to be important to be familiar with. As with all of these common medications, we want to have a familiarity with their contraindications. And so with metformin, risk factors for lactic acidosis are going to encompass the contraindications. So examples of risk factors for lactic acidosis would be an impaired kidney function, so a GFR less than 30, if they have active liver disease, active alcohol abuse, if they have unstable or acute heart failure, if they have a history of lactic acidosis while using metformin, or if they have decreased tissue perfusion or hemodynamic instability. So if they meet any of those criteria, then metformin is contraindicated. Typically, metformin is started at 500 milligrams per day, and then it's titrated up to the maximum effective dose, which is generally 2,000 milligrams per day in divided doses. So there are a lot of benefits when using metformin. For one, it's not known to cause hypoglycemia, and so you don't have to be worried about dropping a person's blood sugar with this agent. It has shown to also decrease both food intake and body weight. So if that's a concern, that's a great benefit. It can help reduce the likelihood of cardiovascular events, and it's even been linked to possibly reducing the likelihood of cancer. And so again, there's a lot of benefits when using this drug. The most common side effect reported in patients that are taking metformin is diarrhea. So if they experience diarrhea, then what we want to do is inform them to stop their metformin, and then they will restart it at a lower dose once their diarrhea has completely resolved. And then once they restart that metformin, it's recommended that we slowly titrate it back up to that desired dose. The idea here is that we really want to try and get them back on that effective dose of metformin, but again, we just might have to go low and slow with these patients. Other things that we can do to try and reduce the GI side effects associated with metformin would be switching to an extended release formulation, and also educating them to make sure that they take their metformin with food. So those things also can help reduce the likelihood of those nasty GI side effects. But again, ultimately our goal is if they don't have contraindications to keep them on the metformin. We just might have to slow it down, titrate it down, and then work our way back up to our intended dose. All right, so hopefully you found that information helpful for you while you're studying for your boards, or just if you're looking for a refresher on some pharmacology topics. For the complete pharmacology crash course, because the complete course is about 3-hour long lecture, then go ahead and follow this link. It's patreon.com/BrittanyNP, and I'll put it up here on the screen. And for a limited time, I will be offering this course for only $20. It will also be included in the $40 tier. That is the total review course that I have completed. So that's the AANP and the ANCC review course. So this pharmacology crash course will be available there for you. But for a limited time, I'm actually offering you to purchase just this course for only $20. And as a bonus, if you do sign up for the $20 tier and purchase this pharmacology crash course, you will get access to everything on the $5 tier on my Patreon as well. And the $5 tier is more geared just towards, again, new nurse practitioner clinical pearls. So there's lots of like case studies and visual aids and study guides there for you as well. There's a lot of really helpful material. So it's kind of like a little added bonus that you'll get the pharmacology crash course and then everything in that $5 tier as well. So like I said, it's just for a limited time that you can be able to purchase this for only $20. If you want to see the entire review, it will be about, like I said, it's 3 hours long. We go over tons of material. We cover all of the most tested on medications for each system. So go ahead and follow the link on the screen, patreon.com/BrittanyNP, and you can listen to the full lecture there. Otherwise, thank you so much for tuning in. Don't forget to like the video and subscribe to the channel. I appreciate it. It helps me a ton. I wish you guys nothing but the best, and we'll talk soon. Okay, bye.